Imagine leaking milk from your armpits, or having your own immune system attack your skin, raising intensely painful blisters across your body. And that's not all. You could also face a catastrophic emergency where the uterine wall tears open during delivery, creating a life or death situation in minutes. If you thought part one of childbirth horrors was horrific, then you're in for a stark awakening. Welcome to the Medical Deep Dive, where we're looking at part two of our childbirth horror series. Our mission today is to, well, illuminate some of the most unexpected and challenging medical conditions that can pop up during pregnancy and childbirth. We really want you, our listener, to gain a critical understanding, quickly, without feeling totally overwhelmed. The idea is you feel truly well informed about these often overlooked aspects of women's health. We're about to dive deep into several truly rare and fascinating conditions. So let's jump right into our first one now. We're starting our deep dive with a condition many people just don't even know exists. Accessory breast tissue, also known as polymastia. It sounds like something straight out of a specialized medical text, right? But what exactly does this mean for someone who's pregnant, and how does it actually become noticeable during pregnancy?
Number one, accessory breast tissue, polymastia. Right, so this condition basically means there's extra breast tissue somewhere beyond the two primary breasts. This additional tissue can show up in different ways. It might be a fully formed nipple, or maybe just an areola, or even actual glandular tissue that can produce milk. It's a pretty fascinating example of, well, embryological development going slightly off track. And it often goes completely unnoticed until puberty or, pregnancy. We tend to categorize it into a few types based on what it's made of. First, there's polymastia. That's when you have real glandular breast tissue, and it's got an organized ductal system connected right to the skin. Then you've got polythelia. Now, this is actually the most common type of congenital breast abnormality. We see it in maybe 2 to 10% of people. This involves just extra nipples or areolae, sometimes even just a small patch of hair. It's much more common. And lastly, there's aberrant breast tissue. This is more like disorganized secretory tissue. And it doesn't have that connection to the skin surface.
Okay, so it's not just a single kind of lump. It can look quite different depending on the type. What about how common it is? Does it affect certain groups more than others?
Yeah, the occurrence does vary. Polythelia, the accessory nipple kind, is definitely more common in Native American and Asian populations, and it affects males and females pretty much equally. Polymastia, the glandular type, is less common. The incidence is somewhere between, say, 0.22 and 6% in the general population. It's also seen more often in Asian populations, especially among Japanese individuals. And it's about twice as common in females compared to males. Interestingly, in about a third of cases, it can show up bilaterally, meaning on both sides of the body. If it's unilateral, just on one side, it's usually on the right side in about 64% of those cases.
Wow, it's really remarkable how these hidden tissues can suddenly become so obvious and active during pregnancy. What's the actual reason for this developing in the first place?
Right, to really get the origin, we need to think back to embryological development. Around the 5th week of gestation, so very early on, a temporary thickening forms. It's called the mammary ridge, or more commonly, the milk line. You can picture two faint lines of tissue running from where the armpit will be, all the way down to the groin area on both sides of the tiny embryo. Normally, this ridge just completely disappears everywhere except on the chest, right where it develops into the two main breasts. Accessory breast tissue happens when parts of this ancient milk line just stubbornly fail to regress. They don't disappear, leaving behind extra breast tissue along that original path. And there's a genetic link, too. About 10% of people with accessory breast tissue have a family member who also has it. So that suggests some kind of genetic predisposition.
So it's actually been there all along, but pregnancy is like a switch, bringing it out into the open. What does this actually feel like for someone who's pregnant, especially during the pregnancy itself and, after delivery?
Exactly. Accessory breast tissue is often really inconspicuous until puberty or, like you said, during pregnancy.
Oh.
That's because the very same hormones that drive normal breast development, estrogen, progesterone, prolactin, human placental lactogen, they also act on this extra tissue. This hormonal surge can cause it to develop significantly.
Yeah.
It can lead to pain, especially around menstruation, and sometimes even restrict arm movement if the tissue's in the armpit area. Cosmetic concerns are common, of course, and irritation from clothing, but most notably, this tissue can actually lactate. It produces milk.
It produces milk.
Yes, which is often a really surprising and, frankly, sometimes distressing symptom for birthing parents. And symptoms tied to pregnancy, they tend to get worse with later pregnancies because the hormonal stimulation happens again. We've seen cases like a 31-year-old woman, she noticed some pale lumps in her armpits as a teenager. Just thought they were maybe extra nipples, didn't think much of it. She had some mild tenderness sometimes with her periods, but nothing major. But then around 8 weeks into her pregnancy, she saw these lumps swell up, get darker, and become quite tender. And after she delivered her baby girl, healthy baby, on day 4 postpartum, she started having intense pain and swelling in her armpits. And milk was actually leaking from these accessory nipples.
Wow.
Yeah. And this leakage, the discomfort, it went on for weeks, even while her daughter was breastfeeding normally from her main breasts.
Milk leaking from the armpits, I mean, that is certainly not something you'd expect. Beyond just the discomfort, though, are there more serious health implications for birthing parents who have this accessory breast tissue?
That's a really critical point. This accessory breast tissue is susceptible to exactly the same disease processes as normal breast tissue. That includes things like benign cysts, fibroadenomas, which often show up alongside fibroadenomas in the main breasts, and also mastitis, infection of the breast tissue. But what's even more concerning is the risk of malignancies, of cancer. Accessory breast tissue accounts for a small but, significant percentage, maybe 0.2 to 0.6% of all breast cancers. Some data even hint at a potentially higher rate of cancer in accessory breasts compared to the pectoral breasts. One theory involves stagnation in the ducts, but maybe a more accepted idea is just delayed diagnosis.
Delayed diagnosis.
Yeah.
Because people just aren't aware of it.
Exactly. Lack of awareness among both patients and, frankly, healthcare providers too.
So that difficulty in even knowing it's there contributes to the risk. What kinds of cancers are typically found in this extra tissue?
Precisely. That diagnostic challenge can really impact outcomes. The most common type of cancer we find in accessory breast tissue is ductal cancer. Infiltrating ductal cancer makes up about 79% of these cases. And the axilla, the armpit area, that's the most frequent spot for these cancers, accounting for somewhere between 55 and 91% of them. This really highlights how important vigilant screening is. People with accessory breast tissue should have it screened right along with their primary breasts. Standard mammography might not always get the best view of axillary tissue, but special views, like oblique and exaggerated craniocaudal views, can usually get satisfactory images. On mammograms and ultrasounds, this tissue looks identical to normal breast tissue, but it's clearly separate from the main pectoral breasts.
And what about the prognosis for these cancers? Is it different from cancers found in the primary breast tissue?
Unfortunately, while the data is somewhat limited, accessory breast cancer does seem to have a poorer prognosis compared to cancer in the main breasts. Some theories suggest maybe it's due to more frequent or faster spread to the lymph nodes. But other perspectives argue that the poorer outcomes are mostly because of that delayed diagnosis we talked about, often due to the difficulty in spotting it, especially with aberrant tissue, and just a general lack of awareness in the medical field. This idea is kind of supported by the fact that the prognosis does correlate with the stage of the disease, and it's often diagnosed later. Beyond cancer, there are some, controversial associations, especially with polythelia, the accessory nipple type. Some studies have linked it to kidney problems like extra kidneys or even renal carcinoma. One study reported about a 14.5% incidence of renal issues in affected patients compared to maybe 1 to 2% in the general population.
But that's controversial.
Yeah, other studies haven't found that link at all, so it's still debated. There are also some disputed associations with cardiovascular disorders, pulmonary hypertension, cardiomyopathy, high blood pressure, and other unproven links to things like vertebral disease, pyloric stenosis, testicular cancer, even familial alcoholism. But those are much less certain.
Okay, a question for our listeners. If you have experienced accessory breast tissue that caused significant discomfort or concern during pregnancy, what specific advice would you offer to someone newly discovering this condition? How would you suggest they approach discussions with their healthcare provider to ensure they get comprehensive care? Let us know your thoughts in the comments.
Okay, so moving on to management. Generally speaking, there isn't a strict medical need to remove benign accessory breast tissue. But cosmetic reasons and practical issues are very common reasons people seek treatment. Many individuals choose surgery because of how it looks, or difficulty with arm movement, or that discomfort from engorgement, especially during periods or pregnancy. And of course, there's the understandable worry about the potential for malignancy. Historically, the main surgical approach was, pretty gross excision. And even just 15 years ago, this had really high complication rates, around 39%. Things like unsightly scarring, leftover tissue. In fact, one study back then actually discouraged surgery because so many patients came back unhappy with the cosmetic results.
Wow. That sounds incredibly frustrating if you were hoping for relief and ended up with new problems. How have things improved since then?
Thankfully, yeah, modern surgical techniques have really improved patient satisfaction and cut down on those negative outcomes. We now have things like the precise use of liposuction, sometimes on its own, sometimes after surgically removing the tissue. Also, strategically using elliptical incisions along natural skin tension lines helps minimize visible scarring. Minimally invasive incisions are also used more and more, giving less invasive options. Some surgeons might even suggest reducing the primary breast tissue at the same time, using the same incision, if that's something the patient wants. The impact of this condition can be really significant. Remember that 31-year-old patient? After experiencing all that discomfort and milk leakage, she specifically sought a surgical referral before planning her next pregnancy. That really shows how much people want relief.
Yeah, that real-world example definitely drives home the impact. Okay, let's shift gears now to our second condition. This one has a name that kind of gives you a hint. Mirror syndrome. It's a rare situation where the birthing parent's body dramatically, reflects a problem happening with the developing baby. What exactly is mirror syndrome?
Number 2, mirror syndrome. Yes, this is indeed a rare and complex condition that pops up during pregnancy. It's defined by the pregnant person developing significant edema that's swelling from too much fluid retention, and it precisely mirrors the edema that's already present in the developing baby. It's quite a striking phenomenon. It usually happens during the second or third trimester, and it's estimated to be quite rare. The prevalence ranges somewhere between maybe 1 in 3,000 pregnancies down to as low as 1 in 80,000. So, yeah, very uncommon.
So the birthing parent's body is almost like a direct reflection of the baby's condition, its distress. What's the actual physiological mechanism behind this? Why does this mirroring happen?
So it all starts with a critical condition in the fetus called fetal hydrops. This is when the baby accumulates an abnormal, excessive amount of fluid in various places, maybe the abdomen, the lungs, under the skin. This fluid buildup in the baby is often because of poor blood flow within the placenta, which means the baby isn't getting enough nutrients and oxygen. Now, in response to these major problems in the fetal placental unit, the placenta itself starts releasing a flood of signaling molecules. They're called cytokines. These cytokines then trigger a series of really profound reactions in the pregnant person's body. They dramatically affect her fluid balance and her blood pressure regulation. Essentially, her body tries to compensate for the baby's severe difficulties. But paradoxically, this leads to her own widespread fluid retention, swelling all over, and high blood pressure.
And those symptoms sound a lot like preeclampsia.
Exactly. They're strikingly similar, which can make diagnosis tricky. But what's really crucial to understand is that it's the presence of the fetal hydrops itself that's the main trigger for mirror syndrome. It's not necessarily the specific cause of the hydrops. And we know this because mirror syndrome has been seen alongside a whole range of different conditions that can lead to fetal hydrops.
That deep connection really makes the name mirror syndrome make sense. What are the key signs to look for, and how do doctors tell it apart from other, more common pregnancy complications like preeclampsia?
The most common and, most noticeable sign in the birthing parent is that significant generalized swelling, the edema. It's often really obvious in the hands, feet, and face. And this is very often paired with dangerously high blood pressure. Some individuals might also get shortness of breath or difficulty breathing, which suggests fluid might be building up in the lungs. A key feature of this condition is something we call triple edema. You see distinct swelling in the birthing parent and in the developing baby, and also in the placenta itself. The placenta often looks noticeably thickened on ultrasound. Now, a really critical difference that helps distinguish mirror syndrome from severe preeclampsia is found in the maternal lab results. In mirror syndrome, you typically see hemodilution and anemia. Hemodilution, meaning the blood is more diluted. Exactly. It's like water's been added, leading to a lower concentration of red blood cells. In contrast, severe preeclampsia usually involves hemoconcentration, where the blood becomes abnormally concentrated because fluid is leaked out of the blood vessels. Diagnosis can definitely be challenging because it's so rare, and the symptoms overlap so much with preeclampsia or just fetal hydrops on its own. There isn't one single test just for mirror syndrome. But prenatal ultrasound is absolutely vital for spotting the fetal hydrops early and any other abnormalities in the baby. Sometimes, getting a small sample of the baby's blood can be really helpful too, to look for specific infections, genetic issues, or blood disorders that might be causing the hydrops.
This sounds like something that could escalate really quickly, putting both the birthing parent and the baby in extreme danger. What are the potential outcomes if it's not caught and managed right away, and what does managing it involve?
The consequences, tragically, can be very severe for both if it's not diagnosed promptly and managed by an expert team. For the baby, the risks are huge. We're talking preterm birth, a very high rate of stillbirth reported in about two-thirds, 66.6% of fetal outcomes. There's also a significant risk of the baby dying shortly after birth, neonatal or infant death, that happens in about 25.6% of cases. So the overall survival rate for babies if the pregnancy continues is, sadly, very low, around 7.7%. And for the birthing parent, the complications can be life-threatening, affecting multiple organ systems. These include maternal heart failure, a really high chance of postpartum hemorrhage that's seen in almost 45% of cases, with nearly 20% needing a blood transfusion. Admission to intensive care happens in about 13% of cases, and there are significant risks of pulmonary edema, fluid in the lungs in about 8.5%, and kidney problems, renal dysfunction in another 8.5%.
Wow, it really hits multiple critical systems hard. How is such a complex and dangerous situation managed, given you're balancing the risks for two lives?
Management is incredibly challenging, exactly because you're constantly weighing those risks. The medical team has to carefully consider the risks for both mother and baby if the pregnancy goes on versus the risks of delivering early. The specific approach depends on several things: what's causing the fetal high drops, the baby's overall condition, how far along the pregnancy is, and how sick the birthing parent is. Because it's so complex and rare, Mirror syndrome really needs to be managed at a specialized care center. You need an experienced obstetric team, ready for potential preterm delivery and equipped for comprehensive, high-level maternal supportive care. The good news, though, is that the birthing parent's symptoms usually resolve quite quickly after the baby is delivered or once the underlying problem causing the fetal high drops gets treated.
Okay, another question for you listening. If you or someone you know went through Mirror syndrome during pregnancy, what aspect of the condition or its management surprised you the most? And what single piece of advice would you offer to another birthing parent who's just received this diagnosis? We'd be really interested to hear your thoughts in the comments. All right, next up, we're turning to pemphigoid gestationis. Now, this condition sounds incredibly complex, and it involves the body's own immune system attacking the skin. What exactly is pemphigoid gestationis, and how does it specifically relate to pregnancy?
Number 3, pemphigoid gestationis. Okay, this is a rare autoimmune blistering disease. And as the name implies, it primarily affects pregnant individuals. It's really, really important to state up front, even though it used to be called herpes gestationis, it has absolutely nothing to do with the herpes virus. Zero connection. Clinically, it's characterized by intensely itchy, hive-like plaques and/or fluid-filled blisters. We call those vesiculobullous lesions. They typically start around the belly button area, but they can potentially spread quite widely over the body. It usually kicks off during the second or third trimester, but sometimes, less commonly, it can show up earlier in the first trimester or even right after delivery.
So it's the body's own immune system mistakenly causing this. Can you explain the biology behind why this happens and just how common it is?
Yes, it's a pretty stark example of autoimmunity. For reasons we don't fully understand yet, the body starts making immune proteins, specifically antibodies, that mistakenly target and attack certain proteins within its own skin. These targets are mainly a protein called BP180, sometimes BP232. These proteins are key parts of structures called hemidesmosomes.
Hemidesmosomes, what are those?
Think of them like tiny anchors. These secure the outer layer of skin, the epidermis, to the deeper layer, the dermis. So when these misguided antibodies latch onto these anchor proteins, it sets off an intense immune response. This leads to inflammation, redness, swelling, fluid buildup between the skin layers. As that fluid accumulates, it physically separates the layers, forming those incredibly painful and itchy blisters. In terms of how common it is, pemphigoid gestationis is quite rare. It occurs in roughly 1 in 50,000 to 60,000 pregnancies. It does, however, have a pretty high chance of coming back in later pregnancies. It affects up to 40% of individuals who've had it before. Flares can also happen after using oral contraceptives, or during menstrual cycles, or around ovulation. And it's particularly common to see significant flare-ups about 24 to 48 hours after delivery.
That sounds unbelievably uncomfortable and distressing for someone going through pregnancy. How is it actually diagnosed for sure, and what are the main ways it's managed or treated?
Diagnosing it relies on a specific combination of things. First, the clinical picture is highly suggestive. Those characteristic super itchy hive-like plaques and blisters showing up during pregnancy or right after. Then, that's confirmed by looking at a skin tissue sample under a microscope. This shows what we call subepidermal detachment, clear separation between the outer and inner skin layers. But the key confirmatory test is called direct immunofluorescence, or DIF. This is done on a skin biopsy, and it visually shows linear deposits of a specific immune protein, complement C3, and sometimes IgG antibodies right along that junction between the skin layers. That finding really confirms the autoimmune nature. As for treatment, the mainstays are systemic corticosteroids, like prednisone taken orally or topical corticosteroids applied to the skin. These are often used along with antihistamines to help manage the severe itching.
So corticosteroids are the go-to. Are there different approaches depending on how bad it is?
Absolutely, it's tailored to the severity. For milder cases, just topical corticosteroids on the skin might be enough. They can lead to complete remission pretty often with a low chance of it coming back. But for more widespread or severe cases, systemic corticosteroids are needed. The average starting daily dose of prednisone is usually around 50 milligrams a day, maybe going up to about 70 milligrams max. It's important to note that the general medical view is that the benefits of using these systemic steroids during pregnancy usually outweigh the potential risks for both the birthing parent and the baby, given how severe the condition can be. Now, for cases that just don't go away or don't respond well enough to steroids, or if there are major side effects, then other immune-modulating drugs are used. We call these steroid-sparing treatments. The most common one is intravenous immunoglobulin therapy, IVG. After that, things like azathioprine, dapsone, and cyclosporine might be tried. In very rare persistent cases, even rituximab has been used. When treatment starts during pregnancy or after delivery, that's decided based on how severe things are and how it's progressing.
Okay, and what about the baby? Are there any specific outcomes or potential side effects for the baby or for the birthing parent related either to the pemphigoid gestationis itself or the treatments used?
Right. For the birthing parent, the outlook is generally pretty good. Most patients, around 84%, achieve complete remission. But a significant number, maybe 60%, will experience at least one relapse, mostly happening postpartum. And about a quarter of patients might have a more persistent chronic course of the disease. In terms of pregnancy and newborn outcomes, nearly 35% of patients end up delivering preterm. Elective C-section is also quite common, happens in about 43% of cases. Often this is because the skin lesions might make vaginal delivery difficult or increase infection risk. Around 13% of babies born live might have some skin lesions that look like neonatal pemphigoid, but these are usually mild and go away on their own. Tragically, though thankfully rarely, intrauterine fetal death has been observed in a small number of cases.
And the treatments, especially those corticosteroids, they can have side effects too, right? What are those?
Yes, they can. While effective, corticosteroids can lead to various issues. Things like iatrogenic Cushing syndrome symptoms similar to Cushing's disease, choroidal diabetes, high blood pressure, muscle weakness, osteoporosis, vaginal bleeding, mood changes, stretch marks. And for the baby, steroid treatment can lead to fetal microsomia, which means a larger than average baby, and also polyhydramnios, which is too much amniotic fluid around the baby. The other medications used can have their own side effects too, like dizziness with minocycline, or elevated liver enzymes with azathioprine, or skin toxicity with dapsone. So monitoring is key.
Thinking about this from a provider's perspective, if you are a healthcare provider specializing in maternal fetal medicine, what unique challenges would you anticipate in supporting a patient through pemphigoid gestationis? And how would you prioritize her emotional well-being right alongside the physical treatment? Share your approach with us in the comments. Now let's move to our fourth topic, amniotic fluid embolism, often just called AFE. This is a truly critical and, frankly, terrifying obstetric emergency. It's known for hitting suddenly and having a devastating impact. Can you describe what exactly AFE is?
Number 4, amniotic fluid embolism, AFE. Yes, this is definitely one of the most critical and sudden emergencies in obstetrics. It's marked by an abrupt and profound collapse of the heart and respiratory systems, and it's accompanied by a severe clotting disorder called disseminated intravascular coagulation, or DIC. Now, the name sounds like a blockage from amniotic fluid, but it's now better understood as the anaphylactoid syndrome of pregnancy.
Anaphylactoid, like an allergic reaction.
Exactly. That term is important because it signals that it acts more like a severe allergic reaction, a systemic immune overreaction, rather than a literal physical blockage. In fact, modern studies show that fetal tissue or amniotic fluid bits aren't consistently found in the mother's circulation in women who develop AFE, even though historically that was thought to be the cause.
The idea of something so sudden, so devastating, it's truly frightening. How often does this actually happen? And what's the story behind how our understanding of it has changed?
Its global occurrence varies quite a bit. Estimates range from about 1 in 8,000 deliveries up to maybe 1 in 80,000. It's hard to pin down exact rates because of challenges in diagnosis and reporting. Timing-wise, about 53% of cases happen right at or just before delivery. The rest happen, on average, about 19 minutes after delivery. AFE was first described way back in 1941. That was when fetal cells were noticed in the lung circulation of women who had died during labor. But our understanding now has really evolved. We now see it mainly as this severe anaphylaxis-like immune response, a massive overreaction by the birthing parent's body, not just a physical embolism. And this shift is backed up by the fact that, well, you can find fetal cells in the circulation of laboring women who don't develop PFE. So the diagnosis now is mostly clinical. It's based on that characteristic pattern of symptoms and only after carefully ruling out everything else that could cause a sudden collapse.
Okay, so it's not just a blockage, but this profound, almost inexplicable systemic reaction. What exactly is going on inside the body during an AFE, and what things might put a birthing parent at higher risk?
So, during an AFE, the initial trigger causes an immediate profound failure of the right side of the heart. It enlarges significantly as it just struggles to pump blood. This then severely impacts the left side of the heart, leading to a dramatic drop in blood flow. This might be due to lack of oxygen to the heart muscle itself, or spasms in the coronary arteries. This whole rapid cascade leads to a sharp increase in pressure inside the lungs and a drastic decrease in the heart's overall pumping power. Severe heart rhythm problems, including sudden cardiac arrest, can happen incredibly fast. Tragically, birthing parents who survive this initial crisis might face severe brain injury from oxygen deprivation or widespread multi-organ failure. Now, several factors are associated with a higher risk of AFE. It's important to remember these are associations, not always direct causes. They include advanced maternal age, having multiples like twins or triplets, problems with the placenta like placenta creta, abruption, or previa, and also preeclampsia. Other factors could be gestational diabetes, too much amniotic fluid, that's polyhydramnios, certain procedures like amniocentesis or amnioinfusion, cervical lacerations, or having had any previous surgery on the uterus.
What are the immediate signs that medical teams are trained to spot in a situation like this? And what's the immediate emergency response look like right there in the delivery room?
The classic picture of AFE involves a sudden onset of really severe shortness of breath, along with dangerously low blood pressure, often happening late in labor. But it's crucial to know that the textbook signs like sudden intense abdominal pain, vaginal bleeding, a worrying fetal heart rate trace, a sudden change in contractions, they are often not all present in every single case. More commonly, what the team might see is a prolonged deceleration or bradycardia that's a dangerously slow heart rate on the baby's monitor. Or maybe labor just isn't progressing normally, or there's a sudden, unexpected stop in uterine contractions. A profound sense of impending doom reported by the birthing parent, along with agitation, anxiety, confusion. These can sometimes come before the more obvious physical signs. Seizures can follow, potentially leading to cardiac arrest and massive bleeding from DIC, often all within an hour of the first sign.
Given how incredibly fast this progresses, what's the immediate sequence? What are the first steps in evaluation and management? It really sounds like every single second counts.
Absolutely. Immediate lightning-fast action is everything in AFE. The very first step is getting blood drawn urgently for blood typing and cross-match, a complete blood count, a metabolic panel, and a full coagulation panel to check immediately for DIC. There are specific scoring systems, like the IST criteria, that help confirm DIC in pregnancy based on things like platelet count, INR, and fibrinogen levels. Bedside coagulation tests can also give quick results to guide treatment for major bleeding. If cardiac arrest happens and the baby is considered viable, an emergency surgical delivery called a resuscitative hysterotomy is done immediately, right there on the spot, not even waiting to get to the OR. Right there. The priority is to improve the mother's condition by getting the baby out as fast as possible, ideally within just 1 to 2 minutes. For the mother, the focus is on securing her airway for oxygen, starting effective ventilation, carefully managing fluids, and early use of vasopressors drugs to raise blood pressure. Getting multiple large 5E lines in is critical for fluids and blood products. If that's not possible instantly, intraosseous lines are used. Epinephrine is given for heart rhythm problems.
Okay, what happens in those moments right after the baby is delivered in such a crisis? How is the birthing parent stabilized?
After the baby's out, the focus shifts intensely to managing that severe bleeding, dealing with a uterus that might be relaxed and not contracting, that's uterine atony, and aggressively treating the DIC. Blood products, packed red cells, fresh frozen plasma, platelets are given immediately, often in a 1.1.1 ratio to replace what's lost and restore clotting factors. Cryo precipitate is often preferred over fresh frozen plasma because it's more concentrated in clotting factors, which helps reduce the total volume of fluid given, something that can be critical. Tranexamic acid might also be used to help reduce excessive clot breakdown. Obstetric procedures to stop the bleeding might include tying off uterine arteries or using special compression sutures, things like B-Lynch, Heyman, or Pereira sutures, to physically squeeze the uterus and stop the bleeding. But in really severe cases with massive uncontrollable bleeding, an emergency hysterectomy, removing the uterus, might be the only option. That happens in about half the patients with severe ongoing coagulopathy. A whole multidisciplinary team, anesthesia, neonatologist for the baby, maybe hematologist, urologist, is absolutely essential. Babies delivered during AFE often have low APGAR scores and need immediate specialized resuscitation.
Okay, thinking practically. Given the rapid onset and severity of AFE, if you were a medical professional on a delivery ward, how would you prioritize immediate monitoring and intervention in those critical first few minutes to maximize the safety of both the birthing parent and the baby? Let us know your thoughts in the comments.
The potential long-term health consequences after an AFE are, well, severe for both. For the birthing parent, complications can be widespread. Kidney failure, heart failure, prolonged breathing problems leading to adult respiratory distress syndrome. Other heart issues can include heart attack, abnormal rhythms, weakened heart muscle, or congestive heart failure. There's also the risk of ongoing bleeding disorders, liver failure, fluid in the lungs, seizures, and anoxic encephalopathy.
Brain injury from lack of oxygen.
Yes, exactly. Brain injury from lack of oxygen. And that can tragically result in various long-term cognitive or neurological problems. For the infants delivered emergently during a maternal AFE, there's a significantly higher risk of hypoxic ischemic encephalopathy, or HIE. This severe oxygen deprivation to the baby's brain can sadly lead to significant long-term cognitive impairment, potentially showing up as chronic epilepsy, motor problems, and developmental delays. Many babies, about 43%, need admission to a neonatal intensive care unit. The overall neonatal death rate is somewhere between 6% and 25%, and it's higher for ruptures of unscarred uteri. Irreversible brain damage in the baby can happen incredibly quickly, sometimes within just minutes of oxygen loss, which is why that rapid intervention is so critical. Right, next, we're discussing something often called pregnancy tumors, or by their medical name, pyogenic granulomas. Now, the word tumor immediately sounds alarming, especially during pregnancy. What exactly are these growths?
Number 5. Pregnancy tumor, pyogenic granuloma.
Yeah, it's absolutely crucial to state right away, despite that alarming name, these are not cancerous growths. Not at all. They are non-cancerous. They're reactive, inflammatory enlargements of tissue. They're a specific type of pyogenic granuloma that happens mostly in the mouth during pregnancy, which is exactly why they got the common name pregnancy tumor. You might also hear them called granuloma gravidum, angiogranuloma, or pregnancy epulis. Basically, it's an over-the-top inflammatory response of the gum tissue.
Okay, so knowing they're not cancerous is definitely a relief. Where do they usually show up, and what do they typically look like? They usually start appearing after the 3rd month of pregnancy, though they can certainly pop up earlier. The incidence is somewhere between about 1.8% and 5% of pregnant individuals. Most often you'll find them on the gums, especially the front part of the upper jaw, but they can also develop on the lip, tongue, the lining inside the mouth, even the roof of the mouth. Clinically, you see redness, swelling, and overgrowth of gum tissue, and they tend to bleed really easily, even with just minor irritation like brushing. They often appear right where there's plaque or calculus tartar, suggesting a local irritant plays a role. How they look. Usually like an outpouching, sometimes lobulated or smooth, reddish to purplish in color, and they feel soft, kind of spongy. It's also pretty common for the surface to be ulcerated, like an open sore.
Sounds like they could cause quite a bit of discomfort or just be really annoying. What kind of impact do they have on daily life, and what's actually driving their development specifically during pregnancy?
Oh, they definitely can cause significant discomfort and disruption. If they get large, they can physically interfere with chewing, speaking clearly, even just keeping your mouth clean. While they're usually painless themselves, the fact they bleed so easily can be a major nuisance. And as you said, they can be a big aesthetic concern for the patient, sometimes causing real self-consciousness. What drives them? It's mostly understood to be those major hormonal shifts during pregnancy. These hormonal changes seem to significantly ramp up the body's inflammatory reaction to common local irritants, especially dental plaque and calculus. The hormonal changes affect the tiny blood and lymph vessels in the skin and mouth lining. Female sex hormones, especially estrogen and progesterone, boost the production of factors that encourage blood vessel growth, things like basic fibroblast growth factor and vascular endothelial growth factor. They also seem to decrease the natural process of cell death. All that contributes to this exaggerated tissue growth. There's also a theory that progesterone might have a slight immune-suppressing effect on the gum tissue, which could make inflammation look more dramatic. But there is still some debate. Some experts point out that the gum tissues might lack specific receptors for these hormones, which would mean their formation isn't directly driven by estrogen or progesterone. So it's likely a combination of factors.
So if someone develops one of these during pregnancy, what's the usual plan? Does it always need treatment?
The good news is, in most cases, these pregnancy tumors shrink and disappear completely on their own after delivery once hormone levels get back to normal. However, if they stick around or if they become painful, get really big, or interfere with eating or talking, then surgical removal is usually necessary. And it's important to remove any local irritants like calculus at the same time to help prevent it coming back. Historically, traditional surgery could lead to more bleeding and slower healing. But thankfully, newer techniques, especially using a soft tissue diode laser, offer big advantages.
Like less bleeding.
Exactly. Minimal bleeding during the procedure, really good coagulation, and much faster wound healing afterward. Other methods have been reported too, like cryosurgery using cold, radiosurgery, and injecting certain solutions directly into the lesion.
Can you give us a specific example, maybe how one was managed or a particularly tricky case?
Sure. There was a case of a 25-year-old woman who developed a pretty large growth on her lower left gum about 4 months into her pregnancy. It kept getting bigger and bleeding, really affecting her speech and chewing, and it was still there a month after she delivered. Hers was successfully removed using a diode laser, and she healed up really well with minimal issues. Another case highlighted a more complex situation, a pregnancy tumor that grew within a pre-existing port wine stain birthmark. These can be tougher to treat.
Why is that?
Well, they can be more resistant to standard treatments, sometimes needing multiple removal attempts, even rarely requiring a tooth to be removed. It's thought that the already increased blood flow from the port wine stain itself kind of feeds the tumor, making it more stubborn and harder to get rid of.
Okay, a question for any dentist listening. If you're treating a pregnant patient with a pregnancy tumor that's really impacting her quality of life and isn't going away after delivery, what factors do you weigh most heavily when deciding on a treatment plan? How do you prioritize patient comfort and safety throughout that process? Share your professional insights in the comments. We'd love to hear them. All right, finally, we arrive at one of the most serious, truly life-threatening complications that can happen during childbirth. Uterine rupture. The name itself just screams urgency and danger. What exactly is a uterine rupture?
Number 6, uterine rupture. Yes, this is indeed a catastrophic obstetric emergency. It means a complete tear, a division through all 3 layers of the uterine wall: the inner lining, the endometrium, the thick muscular wall, the myometrium, and the outer protective layer, the perimetrium. When this happens, parts of the baby, amniotic fluid, maybe even the umbilical cord, can actually move out of the uterus and into the birthing parent's abdominal cavity or the broad ligament area. This creates an immediate life or death situation that can develop in just minutes. While it's rare, it's an extremely critical event with very high rates of serious complications for both the mother and the baby.
That sounds incredibly severe, acutely dangerous. How common is this overall? And what are the main things that put a pregnant person at significantly higher risk?
Overall, uterine rupture happens in about 1 in 11,146 pregnancies. That's around 0.07%. But the risk factors really depend on whether the uterus has a scar from a previous surgery, most commonly a C-section. For individuals without a prior uterine scar, the rate is much lower, maybe 1 per 10,000 to 25,000 deliveries in developed countries. Unfortunately, that rate is much higher in developing countries, often due to less access to interventions for obstructed labor. In an unscarred uterus, causes can include things like direct trauma falls, car accidents, or certain genetic conditions that weaken the uterine wall, like Ehlers-Danlos syndrome. Also, prolonged labor induction or augmentation, or overstretching the uterus with multiples or too much amniotic fluid.
Okay, but it's often said that a prior C-section is the single biggest risk factor, right? Can you explain why that is and how that risk adds up?
Yes, a prior cesarean delivery is without a doubt the biggest risk factor. The risk of rupture goes up significantly with the number of previous C-sections. It's roughly 1% after one prior C-section, but it jumps dramatically to about 3.9% after more than one. So yeah, having 2 or more previous C-sections can make the risk anywhere from 2 to 16 times higher than having just one. Also, a short time between deliveries, generally less than 18 to 24 months, significantly increases the risk too, because the scar hasn't had as much time to fully heal and strengthen. Other pregnancy-related factors that increase risk include having had many previous pregnancies, that's called grand multiparity advanced maternal age, and certain placental problems like placenta accreta, increta, percreta, previa, or abruption. Also, unusual pregnancy locations like a cornual or angular pregnancy, having a very large baby, fetal macrosomia, going past 40 weeks, or abnormal tissue invasion into the uterine muscle, like with a molar pregnancy.
And beyond the pregnancy itself, what about things related to the labor process or specific medical procedures? Do they play a role?
Oh, definitely. Labor-related factors are crucial. Labor that's induced or augmented with medications like oxytocin or prostaglandins generally carries a higher risk of rupture than spontaneous labor. That's because these drugs increase the strength and frequency of contractions, putting more stress on the uterus, especially a scarred one. Now, having had a previous successful vaginal birth after C-section, a VBAC, does offer some protection. It shows the uterus could handle labor before. But it doesn't eliminate the risk entirely. It just lowers it compared to trying labor after a C-section without ever having had a successful VBAC. Certain obstetric procedures also significantly raise the risk. Things like using instruments like forceps or vacuum during delivery, internally manipulating the baby inside the uterus, or applying pressure to the top of the uterus that's called fundal pressure.
Given how incredibly fast this can become life-threatening, what are those critical warning signs that medical teams are watching for, like hawks? And what's the immediate, swift medical response needed right there on the delivery ward?
The signs and symptoms of uterine rupture can actually be quite subtle, and they are often not all present in every single case, which makes it challenging but incredibly urgent to diagnose. While you might think of classic signs like sudden, sharp abdominal pain, vaginal bleeding, a really worrying fetal heart rate pattern, or a sudden change in contractions, these are commonly not all seen together. More typically, the main red flags might be a prolonged deceleration or a sudden, lasting drop in the baby's heart rate, that bradycardia we mentioned. Or maybe labor just stalls, stops progressing normally. Or there's a sudden, unexpected loss of uterine contractions altogether. A significant drop in the birthing parent's blood pressure can also be a really critical sign. Often, the definite diagnosis is only made during emergency surgery when active bleeding and maybe fetal parts are seen in the abdomen. While imaging or labs might help with minor ruptures, in severe cases, the absolute priority is immediate action, surgical delivery, and controlling the hemorrhage.
So, immediate decisive action is the name of the game. What does that critical action look like in the operating room or delivery suite?
It requires immediate, incredibly swift action. If cardiac arrest happens and the baby is viable, an emergency C-section, that resuscitative hysterotomy, is done instantly, right there. The main goal is to rapidly improve the mother's condition by getting the baby out fast, ideally within 1 to 2 minutes, to relieve pressure and help her circulation. Simultaneously, for the mother, it's all about aggressive management of the bleeding. That means getting multiple large IV lines going, transfusing blood products immediately. After the baby is delivered, the team's intense focus is on repairing the uterus if possible. If the tear is too extensive or the bleeding just can't be controlled, then an emergency hysterectomy removing the uterus might be necessary. That happens in about 21% of uterine rupture cases. A whole multi-specialty team, anesthesia, pediatric specialists for the baby, maybe hematologists or urologists, is absolutely crucial for managing this kind of crisis.
And what are the potential long-term health outcomes for both the birthing parent and the baby after something as traumatic as a uterine rupture?
The consequences for both can be profoundly significant, yeah. For the birthing parent, significant blood loss often requires transfusions that happens in about 23% of cases. Injury to the bladder, a cystotomy, can happen in about 11% if the rupture extends downwards. The need for hysterectomy is common, as we said, if the uterus can't be repaired or the bleeding won't stop. Maternal death is thankfully rare in industrialized countries, maybe 0–1%, because of advanced medical care, but tragically it's higher, 5–10% in developing countries. Ruptures on the side of the uterus tend to have worse outcomes because there are more major blood vessels there. For the baby, the fetus or neonate, they are at extremely high risk of oxygen deprivation hypoxia, or anoxia. This leads to acidosis and low APGAR scores at birth. Many babies, around 43%, need admission to a neonatal intensive care unit, in ICU. The overall neonatal death rate ranges from 6% up to 25%, with higher rates typically seen with ruptures of unscarred uteri. Irreversible brain damage in the baby can happen frighteningly quickly, sometimes within just minutes of oxygen being cut off, making that rapid intervention absolutely paramount.
We've explored some incredibly challenging and rare conditions today, from, well, unexpected milk production in unusual places, to the birthing parent's body literally mirroring a baby's distress, from unique inflammatory growths to catastrophic uterine tears. Each one is just a powerful reminder of the intricate and sometimes deeply unpredictable journey of pregnancy and childbirth. Here's a final question for you, our listeners. If you or someone you know has faced an unexpected or medically complex challenge during pregnancy or childbirth, what was the single most vital piece of support or information that truly made a difference for you during that time? Please share your experience and insights in the comments below. We can all learn from each other. Thank you so much for listening to this medical deep dive. Please subscribe to ensure you don't miss our next exploration into fascinating medical topics. And as always, have a nice day or a good night and stay safe.